I'd like to welcome everyone to Palm Beach County Medical Society Services Opioids Education Seminars for physicians and other healthcare professionals. We are part of Palm Beach County Medical Society Services project. We have something called the Opioid Healthcare Response Initiative, which is a task force that we put together back in 2017. The task force has an overarching goal to reduce opioid-related and other overdose-related deaths here in Palm Beach County. And we do this through education, advocacy. We do it through different lenses because it's a complicated problem. We do it through the lenses of prevention, of recovery, treatment, and we left out one, which is rescue. So actually in order, it's prevention, rescue, treatment, and long-term recovery. I might mention that our project is partially funded by the Health Council of Southeast Florida. In addition, I mentioned that we're looking to make this an interactive discussion. So the topic today is basically doctors who do drugs. As physicians, certainly we have the same issues as our patients. We are humans, why not? And our guest tonight is Dr. Sean Fogler. And I'm just going to introduce a few things about Sean, and he'll fill in all the details. So Sean received his medical degree from Ross University School of Medicine. Later on, he went back and completed a residency in internal medicine and a residency in anesthesiology at the Hahnemann University Hospital in Philadelphia. Then he was doing some stuff, got into a little bit of trouble, lost his medical license. He'll give us some of those details. Today, several years later, he's devoting his whole career to education and advocacy in the substance use disorder arena, advocating for important changes in public policy and for educating, again, physicians and other healthcare-related professionals. So without further ado, I introduce Dr. Sean Fogler.
Thanks so much.
So Sean, if you could tell us first what everybody wants to hear about, your story.
Well, I'm not sure we have enough time, but I'll keep it brief to get us started. So I'm actually originally from Canada, came from Toronto to Philadelphia in the mid-90s, and a little bit louder, sorry. And I guess I'll start with my family background because my substance use disorder didn't start till I was in my probably close to mid-30s, so it was quite a bit older. And it really was rooted in trauma. I know many of us think substance use disorders are about drugs, and the reality is that's really just the surface stuff. Like that is, doing a substance or a behavior is really about addressing a problem, finding a solution to a deep-seated problem that the individual doesn't have the resources for. And I grew up in a very well-to-do family, but behind closed doors, there was a tremendous amount of trauma.
So this trauma started at an early age.
I had a very abusive father, and that, at the time when I was a child, I wasn't using drugs or alcohol, but looking back, that was the underlying stuff that created the mindset, the framework, the different strategies to address my own pain and trauma that caused isolation, disconnection, dissociation, a lot of fear, and that is the birth of addiction. Like when you really think about it, and that's where it started for me. And when I look back at my life, like high school and college and medical school, a lot of my behaviors and the things that I did were really to get out of myself. To not be in my own skin, to stay separate, because the reality of how I felt about myself and the shame that I felt as a child that was really put onto me by my father just caused all this really, really destructive behavior. And this wasn't something, we hear about somebody doing a drug and you develop a substance use disorder and things fall apart. This was very slow and progressive over time. And the reality is, I excelled when I was in high school. I was a good athlete, a lot of normal things. Same in college, got into medical school, and and excelled there as well. When I finished medical school, I matched into residency, and instead of going right to residency, I ended up going and working on Wall Street of all places. Don't ask me why.
How did that happen?
Well, when I look back at it, I was always running. I was always looking for something else, right? Medicine wasn't enough. Finance wasn't enough. There wasn't enough adrenaline. I couldn't move fast enough to get away from myself. And so, I really was bobbing and weaving and running for years and years and years. Unfortunately, it put me next to the World Trade Center during the 9/11 attacks. And that was a massive traumatic event that, so I had this PTSD, which at the time I didn't even know I really had it, but I had this horrible traumatic experience. I knew some people that had died there. And that was layered on top of this kind of complex PTSD and trauma that I never addressed, I never dealt with. And so my solution after 9/11 was to really just go back to work, and I went back to residency,
So from Wall Street back into medicine.
right, back into medicine. And in some ways it was a great place to hide because you're working constantly, you're being exposed to high stress. There is that work hard, play hard kind of attitude. And there's also this culture of silence, that you don't share your pain. You don't share if you have a mental health issue or you're experiencing trauma as a physician. And so that really caused, I would say, my isolation and disconnection to deepen even more, even though on the surface, if you looked, I was very engaged with friends and colleagues and going out and doing things and 2 great kids and great schools, all the things that people are like, oh, that guy's got it, got everything. He's doing great. But inside, I was really, dying. And
This is during your residency
This
training
is during
now?
my residency, and really becoming very disconnected, very dissociated, but excelling at work. Patients loved me, my program director loved me, and on the surface, everything looked fine. And the reality is, I never even thought about asking for help. I didn't even have the insight or the recognition that I knew something was wrong, but I didn't really understand how disconnected I was from myself and from the world around me. And so bit by bit, and that's where I started to use substances to address, and I was using stimulants, I was using cocaine, and it worked great. The reality was, I felt great, energized me, dopamine levels nice and high, I felt fantastic. I tried antidepressants, like after 9/11, I hated how they made me feel. And that's slow, and that was a slow progressive thing too, because I wasn't using it every day. I was occasionally using it on weekends. But bit by bit, I was using it more and more and more. And I would say the last year and a half before I went to treatment, things got really bad. I was using it almost every day. I wasn't using it at work, but obviously I was impaired. And I remember there's this one event where my wife was holding my son, who I think was about 2 at the time, and we were in our kitchen, and she looked at me. It was like, I don't know who you are anymore. And for some reason, something went off in my head, and I was like, wow, I'm completely disconnected. I was scared. I was scared because, I don't know how I'm being perceived by the world. I don't know how my actions and my behavior are affecting other people. Just completely disconnected. And right then I agreed to go to treatment. And within a week, I actually came down here to Florida, to Delray. I dove into treatment. I spent 3 months. They talk about these pink clouds. I don't think I ever saw pink clouds, but things dramatically changed very quickly. But it was also really challenging, to face a lot of that stuff. But the reality is those first 3 months, that's like the first step. That's like, I didn't realize it at the time, but the real work starts when you leave, drug and alcohol treatment. And
So this was after your residency during?
Yeah, I had practiced for about 10 years.
Okay.
By the time this happened.
And this was an ongoing struggle while you were working?
Correct. correct. So that's why I say it was a long, slow, progressive process, which, in some ways it's like, some ways I wish it was quicker and faster and something bad happened and I addressed it, because it was so long and slow and progressive, and it allowed the problem, I think, to really like amplify itself and get into like all sorts of different areas of my life. So when things really fell apart, they fell apart in a very big way. And so, initially I went to treatment. I came down here. Then I went to a place in Kentucky called The Bridge, which was incredible, which was like much, much deeper work. We did like empty chair work and did like all sorts of different types of therapy. And it was amazing. It was transformative, and it changed my life. And I came out of treatment, and probably the first 5 or 6 months, I just went to meetings. I didn't even go back to work. I was going to meetings all day. I was reading a ton of recovery related related work, stuff on spirituality, because the reality is I didn't believe in anything before I got into recovery. Nothing, myself, which was not a good strategy at all. And bit by bit, after about 5 or 6 months, I started to go back and practice anesthesia. And I was doing a couple days a week, but because of my experience, I wanted to do addiction medicine. And so Karen in Wernersville had one spot at the time, and I applied. I didn't necessarily think I would get it because there weren't many addiction fellowships in the Philadelphia area, not addiction psychiatry, but just addiction medicine, which is separate. And I miraculously got the spot, and I started the program in July of 2016, which was amazing. I was like, man, like I found my calling. I love this. Like, anesthesia to me was very. I always say it was like I was laying brick. It was just kind of a cog in the wheel, doing cases. And this was something I was so passionate about. Obviously, I had like lived experience, and it was like just so important to me.
You started an addiction medicine residency.
Fellowship. It was a 1-year fellowship. So I get maybe almost 4 weeks into the fellowship, and I get arrested. And I was almost 1.5 years into recovery at the time, and obviously, physician getting arrested, drug charges, they stack the charges, your face is in the paper. Talk about trauma, like that made 9/11 and the other stuff look like nothing. And so there's a lot of shame, isolation, professionally, personally. And the reality is the only way I got through it was through recovery. I mean, through the community, the people that I had met in the rooms, they literally held me up because, I wanted to die. And I thought, my life was over. And
so this arrest was because of something that happened earlier?
So I had written to this woman who I was hanging out with who had, a drug problem just like me. I had written her 7 prescriptions, and obviously I was using drugs, and so, yeah, it was related to that, yeah.
And it surfaced actually when you were already into the recovery process, right, and actually seriously doing a fellowship.
Right, yeah. The irony
kind of
is
ironic,
pretty, the irony, yeah, there are many ironies, yeah. Layers and layers of irony, but yeah. So prosecutor didn't care. The prosecutor's attitude was, you're a physician, you should have known better, and, I wish that was the case. I wish physicians, and lawyers and other educated, people didn't suffer from these things, but like you started out with, we're human beings, and but it didn't really matter. The reality is, they wanted to make a point, and they did. That case took about 2 years to wind through the courts, just waiting, which was painful too. Obviously, my license was suspended pretty much immediately in the state of Pennsylvania, and and I didn't know what to do, and ultimately I was like convicted of a drug, of writing a script that I shouldn't have, and my license was suspended, and I was searching for something to do, I didn't know what to do. I wanted to do something in this space, and I met somebody that ran a harm reduction organization in the state of Pennsylvania, and I started doing harm reduction, like public health related work. And a lot of that work was funded actually by Bloomberg Philanthropies. We were working on syringe service legislation. One of the first things I was hired to do was train law enforcement across the state. So you can imagine what that was like, right? I was like, first of all, I was like, have you read the paper? Are you guys out of your mind?
And that article is still on the internet. If you do a search,
which one? Oh, there's all sorts of. Oh, yeah, and there's
easily accessible.
Yeah,
right?
and there's a lot of like misinformation in there, but whatever.
So you've been through a lot of stuff personally.
Just a little bit.
Just a little bit. One of the areas that you've addressed a lot in your writings and in your speaking is the stigma that physicians face having to go through a recovery process or having even to admit that they have a problem.
Right.
Can we elaborate a little bit on that?
Sure. I mean, one of the things my organization does is research on stigma. Initially we launched a large survey last year. More recently we did one on healthcare professionals, and this work came out of my own lived experience with the stigmatization that I faced and like the judgment and the shame and all of that. And the reality is that we don't treat our own very well, right? And I always say that that's the ultimate metric of addressing stigma, which really is discrimination, right? The classic definition is, it's a mark of disgrace. And the reality is that, we discriminate, whether knowingly or unknowingly, against this patient population. And one of the realizations I had, because I started doing all this law enforcement and criminal justice related training, and then training healthcare professionals, and seeing the similarities, like our drug policy in the criminal justice system is embedded in our healthcare systems. Now, I think it's more dangerous there because when you go to the healthcare system or the hospital or your doctor, you expect to receive compassionate, evidence-based quality care. You don't expect to be shamed and judged and stigmatized and cast out and dehumanized, right? And so, from my perspective, it's much more dangerous in those settings. In the criminal justice system, you do expect that, right? That's what we expect. And so, and I think a lot of our policies and practices in our systems make it difficult, even for those of us who want to do a better job addressing these issues, to actually do a better job, because the system is designed to keep these patients out, keep them at a distance, minimize risk. It's not about the patient, it's about the institution and about us. And it's not, and I'm not putting blame on you, because a lot of the systemic policies make it almost impossible. And then when you look at the criminal justice side and like the DEA and the Controlled Substance Act, like we're trying to stay alive, because the reality is we've become targets, right? There are some clinicians who absolutely are doing harm and have done horrible things, but the vast majority of them have not, and especially like ones with substance related issues, right? That have had substance use disorders that are unaddressed. And part of the reason why they're unaddressed is because we have this culture of silence.
So if we look at physicians in general, how common is this problem, substance use?
Very common. So our latest survey, we captured responses from over 25,000 Americans and almost 6,000 healthcare professionals. And we found 40% of healthcare, and we lumped all the healthcare professionals because we stratified by like pharmacist, physician, nurse, paramedic, but the attitudes and beliefs were almost identical across the board. So we found that 40% of healthcare professionals either use drugs, have a substance use disorder, or in recovery. 40%. 17% responded as they currently use drugs, right? And then another, I think it was 10 or 12%, identified as having an actual addiction, right? These are anonymous, like we didn't capture any identifiable data, just in terms of the methodology.
This is actually higher than the general population.
This is much higher than the general population, right? But we have this culture of exceptionalism. We think we don't suffer from mental health and substance use issues. And it's like this is a huge issue. And the reality is drugs are ubiquitous. People use them. And physicians are suffering at very high rates, you know?
So with what you went through personally, and you can see physicians who are maybe in some of these early or not so early stages of substance use disorder, what advice would you have?
Well, somebody who's currently struggling?
Sure.
Is that the question? I mean,
Or if they don't even realize they're struggling.
if you don't realize I think part of the solution to this is we have to change the culture, right? Because it's not safe to come out, right, and say, I'm struggling, I need help. I mean, I was just at a medical school a couple weeks ago, and I asked the students, who in here would feel comfortable talking to their chair or program director and saying, hey, I'm struggling with a mental health issue, or I'm drinking too much, you know, and things aren't going well in my life, right? Nobody's comfortable, right? So I think we have to change the culture. And I think part of that, one of the most powerful ways to do that is for physicians that have substance, related issues, that are in recovery, that have been through professional health programs, actually speak out. Because, like for many years I ran the Caduceus, which is the physicians support group in Philadelphia. And the reality is there's a large number of physicians in recovery. Nobody wants to speak out loud about it. Nobody wants to talk about it, right? They want to keep that undercover. And I understand, right? The judgment, the shame, what are my colleagues going to think? Is my institution going to put me out? So I think we need
Which they often do.
that, which they often do, right? Then they'll find creative ways to keep them out. So I think, getting kind of a groundswell of physicians in recovery, and there's plenty of us, speaking openly and honestly about this, an event like this, capturing these kinds of insights, and this is the start of it, right? But there has to be a safe place for physicians to reach out, and there really isn't. I think things are beginning to shift, but I'm not sure how many people in this room would feel comfortable, if they were struggling with an issue. And the reality is, based on the numbers, somebody in here is struggling for sure. So
you mentioned that epiphany for you is when your wife mentioned, you don't seem like the Sean that I know. How important is this outside influence? How important is it for physicians to be listening to people who care about them?
It's tremendously important, and I think like that's part of the solution. Being engaged with people kind of outside of you, because this is a disease of isolation and disconnection, and the more connections we have, generally, we're safer, and getting insight from your colleagues is a powerful strategy. And you may not listen up front, but to know that there's somebody there that's safe, that's listening and is there for you. And that's where peer support comes in. And, I think and there are more and more groups kind of popping up of physicians, working together to support each other around mental health and substance-related issues, private groups not affiliated with the hospital. And that can be a powerful strategy too.
If we focus on stigma for a little bit, you've done a lot of research to document that there's a tremendous amount of stigma within the healthcare system, physician on physician judgment, stigma, this type of thing. What steps can we begin to take to help reduce some of that? And it applies to mental health issues, it applies to all of the substance use disorder, which you can't necessarily separate those two. They're pretty tightly intertwined.
I mean, traditionally we have, separated behavioral health and substance-related issues, which makes absolutely no sense because they are very tightly wound. But there's many strategies. I think having these conversations, Many of you have probably heard addressing language. There's been quite a bit of research on the bias, the implicit and explicit bias that the words we use when you call somebody quote unquote an addict, you say somebody relapsed. These words can trigger a lot of shame, dehumanization, and they signal to the patient, I can't trust this person, I'm not valued, I'm not seen as a whole person. And those can be really harmful, so changing our language is very important. I think evaluating the attitudes, beliefs, perceptions of clinicians and healthcare professionals, evaluating like what that looks like, what do they believe, like looking at social distance metrics, like somebody with an opioid use disorder, you don't want them to marry into your family, you wouldn't want them to be a coworker, you wouldn't want them to be a neighbor. There's very high rates of that with physicians, so evaluating and then designing interventions, educational programs for residents and fellows. And the reality is what I'm seeing is that the younger generation, no offense to the older clinicians, the younger generation is really hungry for change and they want to change the culture. And so I think working with them to create a new culture that values everybody. And I think this is related to diversity, equity, and inclusion, because these attitudes about drugs and people that use drugs are deeply rooted in racism, and that's something that absolutely has to be addressed as well. I think enforcing protections. There's a tremendous amount of discrimination that has been allowed to go on for decades around people who use drugs. So enhancing those protections, and leadership in these medical institutions, they really need to take the lead, right? I mean, it starts at the top and it starts at the bottom.
And I think we'll agree, it needs to start very early on in the medical education process.
Right, so what we know from the research is that as trainees progress through medical education, their attitudes and perceptions towards these patient populations tend to deteriorate. They view them as more dangerous, as a liability, as very high risk, and they'll do anything to keep them out. So education, continuous education and evaluation over time through the training process is critically important, which ultimately I think will lead to a more significant cultural change in the medical community, because the reality is we have to hit this from so many different angles, because it is so tightly wound, like that our drug policy is tightly wound into our medical culture. Even prescribing around medications for opioid use disorder, only about 10 or 11% of people in this country with opioid use disorder access those medications. And the X waiver, and you may have seen the article that I wrote about it, the X waiver is not going to magically reduce the stigma and suddenly the sky's going to open up and everybody's going to be prescribing. Nobody wanted to prescribe before. Less than 10% of clinicians were using that waiver and prescribing medications. So it's something deeper, it's something much, much deeper.
Which takes us to a whole nother controversial area. What is the best approach for treatment and recovery? Traditionally, there's been the 12 steps abstinence model, and then you have the other side. No, we need to put people on medications and that's all they need and they'll do fine. This binary model, so to speak.
Yeah.
Where are we today?
Yeah, today,
how do you feel?
I think from my perspective, there is no single best way. There just isn't. And I think that's part of the challenge with substance use disorders. Like, this is a really complex disease. Like when I look at it, it's maybe one of the most complex issues because it affects psychological, biological, spiritual, from so many different angles. There is no one best way. Like for me, abstinence and 12-step work great. I have friends and colleagues, they can't go to an AA meeting. They're gonna run for the hills and go start, hit the bar, start using drugs. I think we need many, many pathways which lead to recovery, and then and then that begs the question, like, what is recovery, right? Because it's not necessarily abstinence for everybody, and somebody that may have been using heroin problematically now doesn't, but drinks occasionally and goes to work and takes care of their kids and is productive. That may be their pathway. Not everybody will get on board with that, and the one thing that you didn't mention earlier when you were talking about prevention, intervention, is harm reduction, and that's like an area, like that I'm very passionate about, that I'm working on. We need to protect the drug supply because of, our drug policy and prohibition is so dangerous. It's not like the 30s anymore, right? People aren't just going back to the bar and drinking, they're going out and injecting fentanyl, right? Fentanyl mixed with xylazine, methamphetamine, all these different drugs, and people are dying, right? And we were talking about how youth, the rates of youth overdose, that 14 to 18 kind of year-olds are dying at massive rates. And so we need to have honest conversations about drugs, how people can protect themselves, and have this compassionate, empathic, just approach that lets people know that we care about them, that we're there for them no matter what, and when they're ready, if they're ready, we will care for them, right? And if they want to continue to use drugs, that we need to show them how to do it safely and how to protect their themselves, because just sending them out and judging them and dehumanizing them, that's death. It's a death sentence.
This is the whole concept behind harm reduction, where the goal has been said it's more longevity, keeping people alive, as opposed to keeping them off of the substances necessarily.
Right. I think, harm reduction generally doesn't really take an approach one way or the other. It's like, whatever it is, wherever you're at, we're here for you. We're going to love you. We're going to support you. We're going to give you resources. When you're ready, we're here for you. You need wound care, here. You need help with housing. You need help with, food, things to keep you alive, whatever it is. It's so critical because recovery is really hard. As somebody who's like white and privileged, it's really, really hard and challenging. And, for others, it is, almost impossible if you look at it. Somebody without a house, a criminal record, and that's the other thing we haven't touched on, but the criminalization of drugs and people that use drugs, that is something that needs to be addressed as well, because that's a death sentence, for many, many people. And many of the approaches, the stance that the criminal justice system, and I work with a lot of criminal justice stakeholders, to address substance-related issues, actually, it doesn't just not do anything, it escalates the disease. It's actually driving it. Our prisons are filled with people with mental health and substance use disorders. And so the current approach does not work, and that's something that needs to change.
So if we have any questions or comments.
I just had a question about, we all know about credentialing, the 800 pages when we credential for a new hospital, and there's a few boxes that you have to check of, have you ever been treated for a mental disorder? Have you ever been hospitalized? Do you think that having that there is almost preventing people from seeking the treatment that they need, and so therefore they might turn to street drugs? Could that be a possibility, the stigma of it?
I mean, I think there's many that aren't answering honestly, right? I mean, up front. I'm not sure that those boxes serve the purpose that they're intended for. And the other thing that I didn't mention earlier, I don't know why this pops in my head, but it's like, people that are practicing, that are like active clinicians with active licenses, we need to be supporting them and giving them the support and resources to be healthy, because like, I didn't get into the Physicians Health Program in Pennsylvania till my face was in the paper. Now I was a year and a half into recovery. Then they reached out, oh, we want to help you, but the reality is like, the people that you know about, they're helping, but the vast majority of healthcare I mean, you look at, it's a high pressure environment, a lot of stress, depending on your specialty, you may be exposed to a lot of vicarious trauma, like things like that, and that's going unaddressed. One brief story, when it's my second year out as an attending, the nurse anesthetist I was on call with took her life, and I found her. And it was, I don't share this often, but it was probably the hardest, like one of the, most traumatic events of my life. And, I can see it in my mind. But it was like, we found her, they called the police, and they were like, we got cases to do, get back to the OR, right? And it was back to work. and that should never happen. Like, that's a serious, cultural, that's got to change. That doesn't work. We need to support our own,
While we're passing the microphone, I've just tied into that particular question. How much of this goes back to this interpretation that substance use disorder is a disease, is an illness, or is it a moral failing? Or is it some combination of the two?
It's not a moral failing. I don't believe it's a moral failing. I think the disease model, I have problems with it. I think one of the drivers, and I think Nora Volkow talked about this quite a while back, of this whole idea of a disease model, was that if we frame addiction as a disease, stigma will go down, right? We'll see it like diabetes and hypertension, and we'll deliver compassionate care, but that never came to be. And right, it hasn't panned out. I think in some extreme cases of, high dose, methamphetamine over a long period of time, for sure, there are brain changes, genetics are involved where people are predisposed, but it doesn't guarantee that you're going to develop a substance use disorder. And I think the thing we're missing is that, the social, the environmental factors, and even like medical culture itself has created like this environment that makes, mental health issues and substance-related issues, likely things to happen because they're mechanisms to address like issues, right? Whether it's trauma or mental health issues or stress or anxiety, whatever it is. And so, I'm not of the moral failing belief at all. I think the disease model, in some, can be applied, but I really think those social factors, and Bruce Alexander, who's a psychologist from Canada, I think he's retired now, he wrote this book called The Globalization of Addiction, talks about these social factors, these structural factors that are creating the type of environment that makes addiction and drug use a much more likely kind of outcome. So I don't think we can just say, hey, it's a disease, and if you look at NIDA, the National Institute of Drug Abuse, if you look at their disease model, in big bold print, right in the middle is the drug. We've centered the drug. It's all about the drug, and enforcement is about the drug, right? And if we address drugs, if we schedule more drugs, if we, ramp up levels of interdiction and seize drugs, that suddenly this issue will go away. Well, it won't, because it's not about the drug, right? Addiction really is not about the drug at all.
We see that now, especially with fentanyl, and our politicians saying, oh, we got too many illegal immigrants bringing it in from Mexico. Statistically, it's U.S. citizens who are bringing it in, and with the work I've done with a lot of people who are living on the streets and shooting up heroin, they tell me they can order it on the internet and get it tomorrow afternoon. So just by the drug interdiction policy, which isn't a bad idea, but it's not going to
right. And I'm not saying we don't, enforcement, we don't need to enforce, laws and address that, but that's not the primary driver. That's not.
It's not the
and I think it's
solution.
Right, and I think it's part of the reason why we are failing, right, in our approach to address, these
If it's
issues.
not one substance, it'll be another.
Well, you said it earlier, it's whack-a-mole, right? If you read the papers now, some of you may have heard of xylazine, right? They want to schedule xylazine, make that a Schedule III drug. They want to classify fentanyl as a weapon of mass destruction. Really? That is totally ineffective.
Thank you for sharing your story and your experience with us. So one of the things that we do at Karen is we look at the barriers to treatment and ways that we can help families and individuals overcome them. And stigma is certainly the greatest. And I'm wondering, what we're seeing is that people seem more apt to seek help for and speak out about issues related to mental health rather than addiction or substance use disorder, particularly since the advent of COVID, and it's been acknowledged that isolation has harmed a lot of people. I'm wondering if you've experienced that as well, that people are more apt to speak out about mental health issues, that there's less of a stigma there, and if there's any lessons we can learn from that moving forward.
Yeah, I mean, I think generally yes. I think, we've made a lot of progress with depression and anxiety, and people are much more comfortable. There was a study, and now I can't remember, looking globally at different disorders, and they looked at some mental health issues, substance-related issues, criminalization, kind of different levels of stigmatization, and illicit drug use was number one across the globe in terms of stigmatization. Alcohol, I think, was like 4. There is this hierarchy, right? If you're drinking too much, and the reality is, the legal drugs are the ones doing the most harm, right? Alcohol and tobacco are, costing us billions of dollars, and I think we lose about 3 million people globally a year to alcohol-related, disorders. It's massive, but we're not doing anything about that. So
I do think how there's less stigmatization for the person who's drinking as opposed to
it's
the
legal.
person shooting up heroin.
It's legal, right? Yeah, and the way you use drugs, somebody who's, maybe taking a pill versus somebody who's injecting, there is definitely this hierarchy. But the reality is there are physicians injecting drugs, this traverses every demographic, race, like political affiliations across the board. I remember seeing not too long ago I think he was in North Carolina, was a judge who had overdosed on fentanyl and died. And it was just shocking to see a judge, right? Like you wouldn't expect that.
We're all human.
Yeah.
Right. There's another question.
Kind of talking a little bit about cultural and generational shifts in perspective. I'm just wondering what you're seeing in the space that you work in related to THC and marijuana legalization, usage, and then how that might kind of be playing out more in that substance use disorder and the space. It's such a dramatic shift that we've seen in recent years with legalization and usage.
Yeah, the people in my space are definitely for legalization, and I think like a lot of that, I think the biggest part of that is the criminalization piece, right? Like nobody should go to jail for marijuana, right? But marijuana today is much different than it was in the 60s, right? The potency. And so there are issues related to that. It's interesting because my daughter's in high school, and we were talking about that earlier, and marijuana use is rampant.
Yeah, the kids don't drink anymore. I have a teenager as well, and alcohol use has gone down dramatically in that demographic, but of course then, marijuana usage has gone up quite a bit. They're vaping and doing all that. So I'm just curious kind of what the impacts might be culturally and in terms of substance use disorder with sort of this early and chronic use.
Yeah, I think it remains to be seen. We've seen youth overdose deaths skyrocketing. And so, I don't believe in the gateway drug theory, but clearly, if people are using marijuana, I don't know, are they going to maybe I'll try
this.
And just
the lethality too, right, of the substances now is just.
Right, and edibles that are lasting 8, 10, 12 hours. And then what are they laced with, right? We're seeing pressed pills that are, and so you don't really know. I recently just joined the board of the Bridgeway School, which is the first recovery high school in Philadelphia. And it's very interesting to hear from the city, they're like, we're not dealing with marijuana. We don't even want to hear about it because everybody's doing it. And so I think it's a discussion we need to have. I think it goes back to having honest and open conversations with students about drugs, the realities of drugs, not the Just Say No, not the DARE program. No offense if anybody's working with DARE, but but I think we need to have a real conversation and equip them with the knowledge, and strategies to protect themselves. Because I know my kids are going to be in a situation where they are challenged and they might take something, and I don't want them to die.
And to that point, there becomes an ethical question. Okay, just say no, don't do drugs. Do we ethically have the right as physicians to impose that on people? You know, we have statistics that show, and this is playing the devil's advocate, but we have statistics to show only 15 to 30% of people actually develop addictions to these substances. Are we possibly over pathologizing everyday life?
Well, for sure. I mean, most drug use is not addiction. It's just not, and that's why, I mean, I think we have to have open, honest conversations. I think it's our responsibility to educate that, give them, you know, the facts, and equip them with strategies to protect themselves. I think that absolutely should be our responsibility.
Hi, my name is Jake Teisch. I'm a psychiatry resident working locally. I have a question. You spoke a little bit about trauma, and so I was curious, do you think there's enough emphasis placed on trauma and helping individuals recover from said trauma in the world of recovery in general?
Generally, no. I mean, the reality is addressing trauma first of all, it takes a high level of expertise. It takes time. It takes a lot of work on both sides, not just for the clinician, but the patient. I mean, I've spent my whole life like addressing my own trauma, and it's a lot of work. But I think it's really important because I know for me, like, once I address the trauma, all the other stuff falls away. I'm not interested in using substances and running for myself and all that. So I think it's so critical and important. You know, I think there's a lot of funding coming down the pike, especially opioid related, you know, funding, that we have an opportunity to build a better system, a more robust system that, you know, and that could be, I think, is an important part of it, addressing underlying trauma. Because I think for the most part, that is like, that's kind of the birthplace of addictive disorders, is trauma, for almost everybody, you know. So the short answer is no. That's the longer answer.
So how about the fact, and you referred to that just a little while ago, that traditionally we've operated out of silos. There's mental health issues here, addiction issues here. How common is that still in this day and age? How optimistic are you that that's going to evolve into something more efficacious?
I think it's changing. I think people are realizing that these fragmented, disconnected systems are not working and we need to integrate. But there is a lot of, especially with private entities, like they don't want to play nice. They don't want to integrate. They're, you know, it's, I think capitalism is a big part of that, right? But we need an integrated system of care because that's the ultimate solution. Because, you know, okay, asking for help, that's really hard. Going to treatment, that's really hard. Leaving treatment, it's really hard, and you need those supports, right? Like around you, and it takes years, you know, to address these issues. You know, obviously my stuff was kind of a lifetime of issues that progressed, and then, you know, I'm still working on it, and next month's like 8 years in recovery. But it's, you know, it's still a bumpy ride. I don't think we can expect people to heal and really address the underlying issues that drive the behavior without, you know, building up our system and integrating it and coordinating it and providing many different pathways. You know, it's, but I think we have an opportunity now. I think there's a realization. I think COVID has helped with that. You know, COVID was so traumatic. I think one of the good things about that is that it like opened our eyes and you know, was a bit of a wake-up call to, you know, the inequities and the fragmentation and the suffering and that exists in American culture. And so, you know, I think, like, I'm excited, like, things are so chaotic now in many different ways, but I'm excited about this time in history because I think, you know, when things are chaotic and uncertain and the ground's shifting, and that's like the time when I think things can really, you know, we can make a big shift in a much better direction.
And also coming out of COVID, telemedicine ramped up tremendously. Do you not feel that that could also be something very positive in terms of management of folks with
Absolutely.
substance use disorder?
Yeah, I think that's huge, and I actually think that that's one of the simple strategies that we can use to kind of break down like that stigma, because the reality is, and in some of our surveys we ask this question, like people that are using drugs, people with substance use disorders, people in recovery, they don't trust our healthcare systems. We have a long history of discrimination and judgment and shame and all the stuff that I mentioned. And so we have to change the narrative, change the culture, and part of that's like getting patients to trust us, right? That we are there for them. We're not going to harm them. We're going to advocate for them. And I think like telemedicine, can be the start of that, right? You don't have to walk into the office or go to the clinic and maybe looked at a certain way or spoken to a certain way. You can get online and see how it is. Oh, I kind of like, I like my doc, and develop that at a bit of a distance. So I think it's really powerful. And then I think for, people that are disconnected and disengaged, to be able to just pick up their phone, and not everybody has a phone, right? But a lot of I think 85% of the U.S. population's online or has some kind of device. To be able to just engage, with a healthcare provider and get help, it's like a safe way to do it. So I'm excited about that. I think that's the start of something great. And the reality is, you don't need a face-to-face visit for everything. I mean, histories and physical.
Contact.
We need
to know your doctor
sure.
cares about you,
Right.
and you're connected.
Yes.
So let me just ask you for a moment about recidivism. This is a big part of this whole arena, whether you're going through medical treatment, whether it's 12 steps abstinence, whether it's something in between or some other combination altogether, the rates are pretty high. Is this a bad thing, or is this just a normal part of the process?
When you say recidivism, you mean like recurrence of use, like somebody coming back?
I had a patient
think,
come in to see me. I'm a dermatologist. He came in for some skin thing. So, how you been? Because I haven't seen him in a few years. He goes, well, last year was really terrible. He goes, my 26-year-old died. I go, how was that? He goes, heroin overdose. I go, what happened there? He goes, he was in and out of recovery programs 152 times.
I think the rates of like recurrence are comparable to any other disease, like diabetes, hypertension, people with hyperlipidemia. Like there's no difference, and so I think it happens, I think it doesn't have to be part of the process. Many people get into recovery, they stop using substances, that's it, right? Many people, they vacillate back and forth, and it takes time. And the reality is, like we've been saying, the recurring theme, it's not about the drug. Like people are medicating, like they're dealing with trauma and mental health issues, like other life challenges. And the drug, we have to ask, what is the drug doing? Like the drug is serving a purpose. And frequently you ask somebody, okay, to stop using drugs. Well, now you've taken their coping mechanism away from them, and the psychic pain is unbearable, and like emotional and physical pain are experienced in similar areas of the brain. It's like getting gutted with a knife, but now you have nothing to medicate yourself with. So I think it's kind of part of the journey, and it happens, and we have to be prepared for it. And we have to deal with it in a compassionate way, so
as someone who has been through this personally, what gives you the confidence that you won't be one of these individuals who will read about 5 or 10 years from now that cycled back?
I don't know. I don't know what tomorrow will bring. Today, I have many different coping strategies that I never have. I have a recovery community around me. I do a lot of different things with mindfulness and meditation. I've spent a lot of time addressing my trauma. there's no guarantees. I can't tell you, with 100% certainty, but I can tell you I'm in an infinitely better place than I ever was. I'm much healthier today than I ever was before. A friend of mine who's in recovery, who's a psychiatrist, who has maybe a wilder and crazier story than me, he always says, isn't it interesting, when you were all messed up and struggling and out of your mind, they let you practice, but like today, when you're healthy and you're in recovery and you've got all these supports, they won't, right? Now, the reality is I'm at the point where I could go back and get my license, but it is an interesting, kind of thing, like if you think about it.
Another irony, so to speak. So I'm just going to ask you one more question. We're talking about this high school that you're on the board of. This is something new to me, hearing that there are recovery high schools. Can you tell us just a little bit about that concept?
Yeah, so I think it was born out of collegiate recovery programs, which there are many around the country. They're kind of growing, and they are to support students that want to be in recovery. And for schools, that usually is abstinence. Now, many of these schools, like if somebody, as long as they have the desire to stop using and they're working towards it, they're there to support them. So what they would do is they would leave, like for somebody in high school, right, has a substance-related issue, high school program is modeled after that original, except they have peer support, mental health counseling, they do meetings, they're in a supportive environment that can help them. And considering, drug use, marijuana use, things that are going on, overdoses related to use, this is like a really powerful, I think, preventative strategy. I think this is something that we should target. Opioid settlement money should be funding these programs, and we need, like in Pennsylvania, there's only 2, which is shocking to me.
In Florida, I looked it up, we have 3. There's one in Jacksonville, one in Orlando, and one somewhere's on the West Coast. So nothing down South Florida yet. So,
right. So how many spots would you think,
we could use a few more.
Right.
So in these schools, these are all basically adolescents who
Correct.
have drug problems.
Correct.
So there's this
Some of them have
criticism that if you put all these type of kids together, how is that going to be positive? They're all kids who've been using drugs. They're going to, feel socially connected and go back to those ways.
Yeah, I mean, that's, I think, been one of the arguments against peer support forever, but we know peer support is such a powerful strategy, like other people in recovery supporting each other. So I don't believe that at all. I think, that the cohort and the relationships and the connections there under the guidance, of the therapists and the teachers that are all on board with that can be incredibly powerful, right? They have friends that are in recovery, right? They go and do things together, and it's like, recovery shouldn't be more isolating than addiction, right? You know what I mean? You don't get into recovery to sit in a church basement and hide from the world, right? You get in there so you can live, right? And thrive, right?
Society.
Right, and thrive and be, one of the, I guess the North Star for my organization is that, we want to get society to see and treat people that have substance-related issues as equals, and the reality is, we're not.
So in this arena, in closing, what do you see as your future, and what do you see as the future for the whole system?
Yeah, I mean, in a dream, it would be, equity and equality across the board, where, somebody, with a substance-related issue can go to a hospital and be treated as an equal, get treated just like a diabetic goes in, or somebody with some other issue. In terms of society, employment, discrimination just in general society, being able to get loans, be able to live in society as an equal person. People in recovery that have been impacted by substance-related issues, that have been impacted by the justice system, it is a life sentence, right? And so I think the future is creating the type of drug policy that makes them equal. Makes them equal, just like you and me, which they are. They're human beings. You started this off with, right? We're human, right?
And how
So-
optimistic are you that we might reach this goal?
Well, I think I think I have to in our lifetime. Yeah, I'm not so sure about that, but I think things are beginning to shift. We're making a lot of headway, but it's a very bumpy road, and we have a long, long, long way to go because we have to untangle, this historic drug policy rooted in racism, gender bias. It's such a tangled web of discrimination and dehumanization that's gone on forever. I mean, it's in our history. And so I think it's going to be very challenging, but I am optimistic that things are beginning to change,
Dr. Sean Fogler, thank you so much for being here this evening. It's been a most interesting and provocative discussion.
Thank you.